Welcome to Deep Dive Ortho. Today we're taking a closer look at a really common issue, acromioclavicular arthritis. It pops up all the time in practice, doesn't it? Sometimes straightforward, sometimes, well, quite tricky. Our goal today is to really unpack it for you: anatomy, diagnosis, treatment, the lot. And guiding us through this is Prof. Mo Imam. It's great to have your expertise to shed light on AC arthritis. We want to equip you, our listener, with a solid understanding to help you diagnose and manage this in your own practice. So let's get into it.
Gotta be here.
Right, let's kick off with the fundamentals then. What exactly is acromioclavicular arthritis, and just how common are we talking in orthopedics?
Well, AC arthritis is essentially osteoarthritis affecting the AC joint. Simple as that, really. It's the cartilage wearing away where the acromion and the clavicle meet. And it's not just a cause of AC joint pain. It's recognized as the most common disorder affecting that joint. Full stop.
The most common, okay.
Yes. And while you might think arthritis means older patients, and it is more common with age, it can actually show up much earlier, sometimes even in the second decade.
Second decade, wow.
Yeah.
That's really quite young. So it's definitely not just an age thing.
Exactly.
Who else then tends to be particularly susceptible if it's not just about getting older?
Well, we see it a lot in people doing repetitive, heavy overhead stuff. Think weightlifters,
Bench press, overhead presses.
precisely those. Or overhead athletes, throwing sports.
Yeah.
The root cause is often this repetitive microtrauma. You've got large forces going to a very small joint surface area.
Yeah, okay. Makes sense.
And then there are other risk factors. Previous injury is a big one. A clavicle fracture, maybe some AC instability in the past.
Yeah.
That can lead to post-traumatic arthritis down the line.
Right.
Also things like distal clavicle osteosis, bone resorption at the end of the clavicle, or inflammatory conditions, rheumatoid arthritis being a classic example, even post-infectious causes like septic arthritis.
So quite a few potential triggers then, beyond just wear and tear.
Indeed.
Understanding the joint itself seems key here. Could you walk us through the essential anatomy and biomechanics? Maybe highlight what makes the AC joint unique or perhaps vulnerable.
Absolutely. So the AC joint is a diarthrodial joint. Freely movable, it's where the lateral clavicle meets the acromion. Now, one interesting feature, maybe less appreciated, is that it often has a fibrocartilaginous disc inside, a bit like a small meniscus in the knee.
A meniscus, really?
Sort of, yes. Helps with shock absorption and load distribution. But despite that, it's a small joint surface taking relatively high loads, both axial and rotational. This means pretty significant contact forces, especially if that disc starts to degenerate or if the joint surfaces are oriented at an oblique angle, which they often are.
And stability. What holds it all together under those loads?
Good question. Two main sets of ligaments. You've got the AC ligaments themselves running horizontally across the joint. The posterior and superior parts are the strongest, providing that horizontal stability. Then, critically for vertical stability, stopping the clavicle moving up and down, are the coracoclavicular ligaments, the CC ligaments.
The conoid and trapezoid.
Exactly, the trapezoid and conoid. The conoid inserts about a 4.5 centimeters from the end of the clavicle, and it's really vital for that superior-inferior stability, a key structure. You also get some stability from the surrounding deltotrapezial fascia, the capsule, and the muscles crossing the deltoid and trapezius. And innervation is interesting too. Branches from the suprascapular, axillary, and lateral pectoral nerves supply the joint.
Which explains the referred pain patterns.
Precisely. That's why patients might feel pain not just at the joint, but radiating to the neck, the traps, the deltoid area, even down the arm sometimes.
Right, that makes sense. So, thinking clinically, when a patient presents, what are those classic signs and symptoms? What should make us suspect AC arthritis straight away?
Typically, it's activity-related pain, felt right on the top of the shoulder. It's often worse with overhead activities, as we mentioned, or reaching across the body, cross-body adduction.
The classic provocative test.
Exactly. And pressing motions too, bench press, push-ups. Even just leaning on that side in bed can be painful for many. On examination, you'll usually find tenderness right over the AC joint when you palpate it. Sometimes you might even notice a bit of prominence there from osteophytes forming on the distal clavicle.
And the tests.
Well, the cross-body adduction test is key, probably the most sensitive clinical test we have for AC joint problems. The shear test and the Paxinos test are also useful additions to your exam.
Okay, practical points there. And what about imaging? Are x-rays the go-to? Are they usually enough?
Imaging is definitely important, yes. Radiographs are recommended. The Zonka view is particularly helpful.
That's the AP with the 15-degree cephalic tilt?
That's the one.
All right.
It gives you the best look at the joint space itself. You're looking for things like osteophytes, joint space narrowing, maybe signs of distal clavicle osteolysis. But this is a really crucial point. Imaging findings often don't correlate perfectly with symptoms.
Ah, the classic disconnect.
Exactly. You can see quite marked arthritic changes on an X-ray in someone with minimal symptoms, or conversely, someone can have significant pain with fairly normal-looking X-rays.
So the clinical picture is paramount.
Absolutely. MRI can be useful too. It might show increased signal, edema within the joint, and crucially, it helps rule in or out other associated problems. Rotator cuff tears, biceps tendon issues, things that can muddy the waters. And then there's a diagnostic injection, putting some local anesthetic, perhaps with corticosteroid, directly into the AC joint.
The gold standard for confirmation.
It could be very helpful, yes. If the pain goes away temporarily, it strongly suggests the AC joint is the source. Though hitting that small joint accurately isn't always easy. Ultrasound guidance is often recommended to be sure you're in the right spot.
Right. Precision matters there. So once we have a confident diagnosis, what's the first line of treatment? What non-operative strategies do we typically employ?
Well, non-operative management is always the first port of call, always. This mainly involves activity modification. So advising patients to steer clear of those aggravating activities, the pressing, the heavy overhead work, reaching across the body.
Managing expectations about certain gym activities, perhaps?
Definitely. Physical therapy is also key, not just for the AC joint itself, but focusing on overall shoulder girdle strengthening and flexibility, parascapular control, rotator cuff function. For pain relief, NSAIDs can be helpful, and as we just mentioned, corticosteroid injections.
Which can be both diagnostic and therapeutic.
Correct. They can provide good temporary relief. But it's important to be realistic. With patients, most don't get long-term lasting relief from injections alone. The effect often wears off after weeks or months.
Okay. So if non-operative measures have been exhausted, or perhaps the symptoms are just too severe from the outset, when do we start thinking about surgery?
Surgery is indicated for those patients with significant persistent symptoms who've genuinely failed a good trial of non-operative treatment, usually several months.
And what does the surgery typically entail?
The main procedure is a distal clavicle resection, sometimes called the Mumford procedure. Essentially, you remove a small amount of bone from the very end of the clavicle. This increases the space between the clavicle and the acromion, stopping them from painfully rubbing together.
Creating that gap.
Precisely.
Yeah.
And this can be done either arthroscopically keyhole surgery or through a small open incision. The choice often depends on surgeon preference and experience.
Are there advantages to one approach over the other?
Well, the arthroscopic approach has a significant advantage, in my view. It allows you to have a really good look inside the main shoulder joint, the glenohumeral joint, at the same time.
Ah, so you can address any other issues.
Exactly. You can identify and treat associated problems. Rotator cuff tears are common, biceps issues, labral tears, all through the same keyholes, often.
That's efficient.
It is. When doing it arthroscopically, the key is precision in the resection. You want to take off about 0.5 centimeter to 1 centimeter of bone. Not too much, not too little. If you're doing an open procedure, then a really meticulous, strong repair of the deltotrapezial fascia afterwards is absolutely crucial for stability.
Okay, that makes sense. Thinking about potential pitfalls, are there specific complications associated with these procedures that we should be particularly mindful of?
Yes, definitely. One major concern is creating instability in the AC joint iatrogenic instability, either front to back or up and down.
How does that happen?
Usually from taking too much bone off. If you resect more than, say, 1 to 1.5 centimeters, you risk damaging the AC ligaments or, more critically, the CC ligaments, especially the conoid. That compromises stability.
Right, damaging those key vertical stabilizers.
Exactly. Another common issue is persistent pain. This can happen if the resection wasn't complete, particularly if a bit of bone's left behind at the back and top the posterior superior aspect. That can continue to cause impingement.
Incomplete resection. Okay.
Other potential issues include heterotopic ossification, extra bone forming in the gap you've created. And with open surgery, if that fascial repair isn't solid, you can get deltoid dehiscence when the muscle pulls away. And it's worth remembering, even with successful treatment, whether non-operative or surgical, a significant minority, maybe 30 to 50% of people with AC joint injuries or arthritis, can still have some residual pain. It highlights just how complex this area can be.
That's a sobering statistic. It really emphasizes the need for careful management. Well, a really thorough exploration of AC arthritis. We've covered quite a bit from who gets it, not just older patients, but athletes too, through the detailed anatomy, the diagnostic challenges, and those crucial treatment details.
I think the main takeaway, for me at least, is the importance of that comprehensive clinical assessment. You really can't rely on imaging alone. The patient's story, the examination findings, that's what guides you. And if you do get to surgery, technique matters hugely. Precision in resection, respecting those stabilizing ligaments, that's key to getting good outcomes and avoiding those complications.
Absolutely. That point about the clinical picture trumping the scan sometimes is so vital, isn't it? It really makes you think. Which leads to a question for you, our listener. Reflecting on this deep dive, especially the points about diagnosis beyond imaging and the nuances of surgical intervention, how might this shape your conversations with patients about their shoulder pain? Could it refine your approach or follow-up strategies? Something to consider. If you found this discussion valuable today, we'd appreciate it if you took a moment to rate and share the show. It really helps us reach more colleagues. Thank you so much for joining us on Deep Dive Ortho. Until next time, keep exploring, keep questioning, and keep refining your practice.